Good morning, everyone, or good afternoon. Good afternoon. Welcome, everyone. My name is Raj Kumar. I'm the president and editor-in-chief of Devex. Delighted to welcome all of you to a very special and exciting event for me. This is an event called the Steps Beyond the Science. You may know this if you've come to some of our other events during UN General Assembly, but I recently published a book called The Business of Changing the World. And I was in that book trying to describe in one section the complexity of the global health challenge for a general audience. And it's a hard thing to do because this is a very complex sector. Even those who have been in it for a long time find it to be a very complex sector. So I told a little vignette that I had heard from an uncle of mine years ago when I was a kid. He's a doctor, and he grew up in India, and he did his training as a medical doctor there. And as part of the training, he had to go to a rural area to practice medicine. It was a requirement, and he went and did that. And he tells me that he used to have patients coming into this little rural clinic, and he would write them he would do some diagnostic and hand them some pills, and that was it. And didn't really have much communication with them. And one day he looks out the window and he sees some of these patients who are trading pills with each other that he had just given them. Pills, 2 blues for 3 reds or something like that. And I tell that little vignette in the book to try to explain that, it's one thing to have the best scientists in the world, the best technologists, the best innovators. And it is true, we are breaking barriers in the science of medicine every day. But actually achieving UHC requires a much deeper systemic approach, and one that actually puts that patient first, that thinks about that patient and their needs, that explains to them what is going on, that thinks of them as someone who is in a holistic way needing access to lots of kinds of treatment. And so UHC is a really big vision, it's a really big idea, but delivering it is going to require an entire ecosystem thinking in new ways. And we, I think, have that ecosystem pretty well represented in this session today, which is why we at Devex, with our partners GSK and Save the Children, are delighted to bring that to all of you here in the room. I see lots of leaders here in the room who work on these issues every day. Thank you for being here. And to all of you who are following this online, thanks for joining the UN General Assembly from the comfort of your own home somewhere all over the world. Maybe a smart decision. UN General Assembly is a very intense time. You need to be athletic to run from one place to the next this week. So thank you all for being here and choosing to be here today. I want to get our panel started right away. So I want to ask our panelists to come up, and I'll just say your names as you come. So you can make your way directly onto the stage. Dr. Pauline Williams, the Senior Vice President and Head of Global Health Research and Development at GSK, one of our partners in this event. Thank you for being here. Dr. Trevor Mundell, the President of Global Health at the Bill and Melinda Gates Foundation. Dr. Seth Berkley, the CEO of Gavi, the Vaccine Alliance. And Kevin Watkins, the CEO of Save the Children UK, another partner in this event today. So please join us. So Pauline, I want to start with you because you work at GSK on the science, which is some of the exciting stuff. You have a lab that you run, multiple labs. You have an open process where you're collaborating with scientists and innovators all over the world. And you're working on some of the disease areas that affect the poorest parts of the world, the people who have the least access to healthcare today. So how do you see, thinking about this UHC context, share with us a thought about how you're working on this today and how you would frame it? Just press the button.
Okay, there we go. Well, thank you for having me here, and it's a great pleasure because GSK has got a long-standing history of innovating in global health, and we're really lucky to have an organisation that really prioritises that, and it's very a source of pride for the employees. Just to zone in on one area that my research team are working on in TB, a huge unmet need and a large proportion of those patients in the developing world, but with the rising burden of resistance, a truly global health problem in middle-income and high-income countries as well. And so thinking about this holistically and the role of partnership throughout, we have open innovation right at the early discovery stage, partnerships with groups such as TB Drug Accelerator that Gates have funded, and that allows really the private sector, pharma, to work together with academics, research institutes, and really share our data and pick the winner, through to product development partnerships to help in the clinical development. But then that's only part of the story, because once it reaches, the medicine is approved and reaches the market, we really need to understand how this is going to land and be effective. And I think starting now, because drug discovery and development is such a long and arduous process, we need to have the patient voice and the understanding of the context of the medicine in 10 years' time to inform our plans now, not to design a medicine for the here and now, because the situation is changing so rapidly.
And some of that does break conventional wisdom in the pharmaceutical sector. And tell me if you agree with this framing. I talked to lots of executives in the sector who say these are businesses that serve the US and Europe and markets where it was a little bit easier to think about access. So actually what they focused mostly on was the science and the tech. And now they're in a position where they're putting all this energy and money into developing drugs for some of the least served people in the world. And they thought, well, we did our job, right? So we developed this thing and it's ready. And yet then they find it's not actually being used. It's really hard to actually get it to the patient. Does that make sense for you from your perspective?
Yeah, I mean, it's the most heartbreaking thing in the world to see some great innovative science deliver a medicine that then just sits in a warehouse and not being used. And so I think this is where the partnership in that last mile is absolutely critical for us to really be clear from the outset that this medicine is going to reach the patients and have the impact it needs. And not only that, but that we've got the infrastructure around that so that the healthcare providers and the patients themselves understand the medicine, and we can track the impact and critically as well from a pharmacovigilance perspective, really understand the safety in the real world.
So Trevor, you at the Gates Foundation, you're leading the effort there to invest in a broad portfolio of medicines. You're doing the drug discovery, and yet this issue matters a lot too. I mentioned at the beginning this idea of putting the patient first. What does that actually mean when it comes to investing in the latest science and tech around medicine, the latest development of drugs?
Thanks, Raj, and delighted to be here with folks, having been inspired by some of the change makers at our Goalkeepers event earlier today. But you know, people have this mantra, they talk about end-to-end and going sort of from research to the patient. And I think the companies know it well, because in some ways they do actually effectively implement something like that across their various markets. From the global health front, I think unfortunately we've had more of a tradition of we've invested in an R&D portfolio, and we're delighted when some new innovation, a new vaccine or a new drug is actually approved. So I'll give you an example right now. We're very hopeful about a long-acting HIV prophylactic drug that could be given by injection, let's say every 2 months. And that might be available in the next 4 to 6 years. But what are we doing? A company now would be at least 4 years ahead of the prospective launch of such a product, would be looking at the market, looking at the patients, trying to understand their characteristics, understand the supply chain, what is going to be needed to make this successful. You know, and global health, I think, and certainly for some of the products we had in the past, we've just waited. So we get approval, then we've got to wait for a guidance committee to give the conditions for use of the product. And it could be 4 or 5 years after the actual approval before significant numbers of people start to actually benefit from this innovation. And that is just far too slow. So I think that one of the actions that more broadly we need to really think about is how do we emulate some of the best practices that companies have used for years, which is how do we get in early? How do we understand those young women who may be the target patient or actually community that would benefit from this HIV prophylactic drug?
Right, thinking of that patient as a customer, having a business model and a business plan around accessing them. I think you planted an important seed in the discussion that we want to come back to. I want to get Seth into the conversation. Gavi is one of the big success stories in global health. It's you know, your name is used in vain on panels like this all over the world to say, look, if you want to invest in global health, there are things that work, like vaccines, right? And perhaps people focus in that on the development of the vaccines or the business model that lets you buy them inexpensively. But a big part is actually the delivery. So maybe you can talk to us a bit about how do you get these to patients? How has that been successful?
So thanks so much for that introduction. And you're absolutely right. Vaccines work. They're fabulous tools and have some of the most cost-effective profiles, in health. So there's no question about that. But of course, vaccines don't deliver themselves. And what we've seen over time now is that we've been able to raise the coverage. And we're now, if you look at the routine system, about 90% of children in the world receive the first dose of a DPT-containing vaccine. So the routine system's getting there. Of course, if you're a mathematician, you can say that 10% don't. And of course, that's not a uniform 10%. So the challenge we have in front of us now is, what do we do about that? And this is where different types of science and technology come in, because what we need is to leapfrog over that last 10%. If they don't get vaccines, they're not getting any health intervention. And where are they? They used to be the hinterlands, that rural Tukul all the way out there, but not anymore. Now they're in urban slums. They're refugees who have been moved because of climate change or other problems. And so what we need to do is be able to track and to work. So this is about providing people with identity, digital identity, if that can be done. This is about tracking the vaccines and being able to, recall people if they missed their doses. This is about changing the supply chain. So everything from having, better cold chain using solar that is ecologically friendly, using nanotechnology, to being able to use drones to deliver in places that have, difficult to access, particularly in rainy season. And what's really cool about this is we can innovate in places where they leapfrog over existing technologies, like the mobile phone is done in Africa, where, they had very few landlines. They now have 800 million phones and a population of 1 billion. We were the first country to have a full country delivery by drone was Rwanda. It was an African country because they didn't have the same restrictions that you'd have in, the company was in San Francisco. But of course, trying to get through the federal, local, FAA, all the other, barriers, they didn't have that in a greenfield place. So I think
and now they're expanding, by the way. You're talking about Zipline. They're expanding from Rwanda to North Carolina.
They're expanding from North Carolina. They're in Ghana now. And what's interesting is it's not only Zipline. We're working in DRC with a different company. There's experiments now going on in the South Pacific, around the world. So this is really exciting technology that can make a difference, and that is the frontier we have to move to now.
I want to get Kevin in the discussion because, yes, there are exciting developments on both the medicine side and the technology side, the ability, the tools to access these patient groups. But a lot of these patient groups aren't the typical customer of a major pharmaceutical company or a major technology company. And the organizations that may know these populations best and serve them best are international nonprofits and even local nonprofits. So how do we engage that community, civil society writ large, into this kind of discussion around delivering drugs at that last mile?
Thanks, Raj. And maybe I'm going to respond to that with an illustration, if I may. From it was actually the first program visit I did when I started in Save the Children, which was to Nigeria, to various areas in northern Nigeria. And I visited a lot of our clinics. And these were clinics that were treating children, many of them malnourished, but with other potentially life-threatening illnesses. And the thing that was most striking is that every pediatric ward I went to, I would say probably around a third of the children had acute respiratory infection, often with something else, with acute diarrhea in some cases, with severe malnutrition. Now, when you speak to the mothers of those children, they all tell you a variant of the same story. And the bottom line problem is that if those children had got 20 cents worth of antibiotics, if they'd been properly diagnosed early enough, 20 cents worth of antibiotics would have solved that problem. If they'd been vaccinated, you wouldn't have needed even the 20 cents worth of antibiotics. Most of them needed oxygen, and there was no access to oxygen in most of the facilities I was in or in the facilities that were treating them. And it really strikes me that, there's so much about health systems, which they're actually not really about innovation technologically. They're about building a structure which is fair and equitable, which puts resources where they're needed in ways that are affordable and accessible to really vulnerable people. And, Nigeria is a country where only 1 in 4 children who presents with symptoms of acute respiratory infection even gets taken to a health provider. And so one of the things that we've been doing in a partnership with University College London and GSK in two areas, one in Lagos and one in the state of Jigawa, is to try to understand why is it that so many children don't get taken for treatment, or they get misdiagnosed, or whatever the underlying problems are. And the research has actually revealed some incredibly interesting findings. And what children have in common is that so many of them are excluded, but they're excluded for different reasons. In some cases, it's because the clinics are just too far away, and they may not be delivering vaccinations in areas that could save their lives. In others, the clinics are close by, but they're private clinics and they're not affordable. Or they're clinics that are just delivering the wrong type of treatment because the health workers haven't been trained. And I think in the end, there's been a lot of discussion this week in UNGA about these things we all believe in, leave no one behind, universal health coverage, motherhood and apple pie. These are all great things. But in the end, it comes down to, do you put sufficient funding into a health system to deliver diagnostic care, proper treatment, where it's most needed? And I think this is an area where we can make a difference working in the sort of partnerships that you've got up here on the panel.
Yeah, and it brings up Trevor's earlier point about the global health sector could be thinking ahead. So if there is a new medicine coming on the market, thinking ahead 4 or 5 years to go and do that kind of research and understand what will the barriers be once we deliver this. Will it be a cost barrier? Will it be a location? Will it be training of health workers? But do we have the business model for that? In other words, is it as easy as us just saying, let's do that now? Or do we lack a change in our models to make that work? I wonder if anybody here wants to pick up on this question of what our business model is for this.
Well, first of all, we need more money for health, and you've mentioned that, but we also need more health for money. And if we look at the numbers, the Abuja Declaration said in Africa that countries should spend 15% on health. There are 2 countries in Africa that are at that metric. And if you look at their overall taxation in the countries, it is way, way below as a percentage term. So this needs to be a fundamental shift. So we need more money coming from into the public sector purse that's available to pay for these activities and build a health system. But that being said, there's also incredible inefficiencies in the system, and that's the really other important challenge. You can do 85% of health can be done through the primary healthcare sector. But, that's not where the investments are going. And the challenge is that it's estimated now around 40% of the investments are wasted. So what we need to do is get more efficient. We've got to change the mix of health workers, and we really have to reach that last mile. And that's going to be the challenge. And it's one last point, which is Nigeria now has the largest number of underimmunized kids in the world. So you pick an example. What's critical is to have political leadership, because there are other countries on the continent that are much richer. We'll hear later from Senegal or from Rwanda or many other countries that are performing much better, their health systems because they have the political commitment.
Oh, go ahead, Trevor.
Agreed that kind of change is absolutely necessary. And you represent, with Gavi and with our other big partners like Global Fund, very effective mechanisms for getting things out there. And then there are, of course, the public systems within countries, which are quite divergent. Somewhere the infrastructure is not great and others better. But I do think to what Kevin said, in terms of really thinking about the model again, what do you do in a country like Nigeria, where 70% of people or so are getting their healthcare in the private sector? Maybe it's from informal providers, from village pharmacies. Similarly, in India, we're a very high percentage. And do we just say that those folks are out of luck if they don't access, the existing systems? Or do we think about some new ways of accessing them?
I just wanted to add, because this assumes that the medicine has been procured and it's addressing how it's going to reach the patient. But there's a step before that, which is this very slow uptake, and what is the evidence that's needed to persuade ministries of health, procurers, to actually invest in that medicine or vaccine over something else. And I think that's where there is a partnership and really efficient use. And so we were in a workshop earlier this week talking about TB TB specifically, around how we can corral all of the players in this space. And the analogy of an orchestra was used in terms of getting everyone playing the right tune at the right time to really start ahead of time to inform us. I alluded to this at the beginning, which is how do we design the best possible trials to generate the evidence that is then going to be convincing that this is an economic benefit to the country to buy this medicine, and what the impact will be. And no company can do that alone. And I think that's where efficient corralling of all of the players to say, let's co-create this plan now so that it's ready by the time this medicine reaches the market, as opposed to, as you said, Trevor, wait till it's registered and then the work starts, which is why you've got this hugely long lead-in time for, many, many years.
It seems like one element of getting ready for the market is what you referred to, Pauline, that's convincing the kind of archetypal finance minister. Make that economic case. Here's why you should invest in TB. Here's the return that you will get. And what you hear from many people who work in the health sector is, well, we just haven't been very good at making that case, that economic argument. And maybe there's some truth in that, but it's also still a deeply political issue. We're talking about deep inequities in a lot of these countries that are not going to be so easy to solve, even with a simple economic case. I see a couple people nodding. Anybody want to jump in on that point? Go ahead.
So look, I think there are two separate but closely related innovation challenges here. So one of them is around how people who are very poor constitute a smaller market. So we do need business models which incentivize innovation for those markets. And I think, what you've done in Gavi through the Advanced Market Commitment is one example of that, and we need more of that. The chlorhexidine work that GSK has led is another example of that. But then there are other types of innovation. For example, I would say one of the most innovative things any government could do with respect to public health is have a proper taxation system in place. And if you spend 2% of GDP on health, you are not going to get universal health coverage. You are not going to deliver marginal groups access to the vaccines that Gavi can roll out, or the sort of products that can come out of the private sector. So I think point one, have a proper publicly financed health system in place as the delivery mechanism for these innovations and health interventions. Second thing is fairness and equity. There's so many times you go to a hospital, like 40% of the health budget in many countries in sub-Saharan Africa goes directly to teaching hospitals in capitals. Where are the children who are most at risk? They are not living in the capital cities. They will never get access to those hospitals. They need properly trained, community-level primary health workers and properly equipped facilities. Now, if you skew resources towards teaching hospitals and high-income groups and call it universal health coverage, on the assumption that one day the benefits will somehow trickle down to poor rural areas, that is a fantasy world. And I just think we need to be much more publicly critical of governments who are making those choices.
And yet we have to make progress in the short term. And so I just think about that, the Abuja Declaration and what you just described as 2% of GDP is low. And look at India, they're spending 1% of GDP on global health, on health in their country. And their big announcement under their universal healthcare plan is to bring it up to 2.5%, which is a really big increase, but it's still a very, very low base. What do we do in the short run as companies are developing medicines that are sitting on shelves? How do we take this forward more quickly, more urgently?
Part of that is this allocative efficiency. I mean, I certainly don't believe that you jump to UHC. You go through progressive universalism, and you start off with the most cost-effective interventions. You try to get them out as widely as you can. You try to make sure they're publicly financed, because if they're not publicly financed, the rich will get them, the poor will not get them. You'll have the inequity problems. You then, when you have enough money, you go to the next and you go to the next. Now, it isn't an absolute, because there are some services you obviously have to have, but that type of rigorous use of resources and prioritization is how you ultimately will be able to move a health system forward. And it's been remarkable, because India, we have seen improvements, and we have seen focus on a lot of the preventive strategies that are going to be critical. And we've seen life expectancy, we've seen mortality rates drop. Now, there are huge pockets of poverty there, and there's lots of challenges still, but we are seeing trends moving in the proper direction.
Yeah, I agree with that. And I think when you think of cost effectiveness, really what you're saying is prevention for the most part, right? You're talking about things that in primary healthcare where you can prevent a lot and therefore save money in the system that you can then invest in other things. But of course, there's a lot of push for diseases that might require tertiary care. There's a lot of political push potentially, and you see in many countries that imbalance today. It's a hard thing to fix. Trevor, I guess from your perspective, you've got this very high-level perspective on this. You're looking at a lot of countries. You're looking at the industry side. You're looking at civil society, looking at government. You're meeting with ministers. How do you see this developing and evolving? What does kind of a new model look like going forward under a UHC banner?
Raj, let me just take this in one direction, which is around some of the new innovations we're seeing coming from pharma and biotech sector, where I'm really concerned that those innovations may not ever be made available to patients or communities in some of the countries that we work in. Take, for instance, two futuristic therapies, gene editing. It's not so futuristic because it's happening in the US right now, in Europe as well, China. And it's going to address certain really tough heritable diseases and other diseases as well. Gene therapy in its current incarnation with hospitalization and bone marrow conditioning and all the auxiliary things that you need to make it successful, never going to be seen in parts of sub-Saharan Africa for a very, very long time. Now you take something that can be treated, sickle cell disease, where we already have seen some attempts at treatment which look quite promising in the US. Most of the sufferers from sickle cell disease reside in sub-Saharan Africa, and they will never have access to the current incarnation of that therapy. So I think it's a time come for us to step back with pharma and with biotech and say that you have these fantastic new innovations. There is a global patient population that can benefit. And let's together think about how at the same time as you might be focusing on certain markets, how can we transform the actual nature of that therapy so that it could be deployed even where the healthcare systems may not be as good as we would like them to be. So you need, optimistically, a single shot, single encounter, in vivo gene therapy that would be curative for sickle cell disease. And that is scientifically in sight.
And what you hear, I think, from the makers of some of these gene therapies is, yes, the price tag is very, very high, but these are curative. And so if we have a different economic model and we pay for this upfront, almost like an advanced market commitment in a way, then the lifetime cost isn't as bad as it might look. And maybe we need some new financial innovation around this to bring some of these very expensive gene therapies to some of the countries that have the biggest burden. I wonder, Pauline, go ahead.
I was just going to say, I mean, it's interesting. Again, it takes leadership. So the highest hepatitis C burden in the world was in Egypt, and probably that was iatrogenic. There's a lot of controversy about where it came from, but they made a commitment to go out and to screen, and over 7 months, I forget the number, they screened
60 million people.
Yeah, and they went and treated people, and they say that they will be hepatitis C free. This is a political commitment. They obviously had to work at getting drugs at a lower cost, but they drove in and dove in and did this for the population. And so I think it can be done. But again, if you ask them how they did that, they said, look, we had to prioritize this because of the cost it'll have later on our system, and therefore we had to use our domestic budget. They actually got some help from the World Bank, but the money came after they finished the process, and they reprioritized to make that happen.
And a big part of how they did it was using new technology. You can't do it in 7 months without the mobile phone and without alerting people and getting people aware and sensitized to this. I wonder, Pauline, just thinking about your perspective coming from GSK, I understand you're now partnering with more other companies in the industry. There's more of kind of a collaborative approach. Why are you taking that approach now? What do you see as the potential to use kind of a coalition to get into these markets more quickly and to accelerate this?
Well, I mean, I think when we're talking about these markets, we have to accept that the return on investment is very low, if at all. And so to me, there's absolutely no point as being in competition. If companies have stepped forward and said we're committed to be making medicines or vaccines in this space, then why would we work in silos? And so I think I mentioned the TB drug accelerator earlier. I think that's a great example where it's sharing data, sharing resource, it avoids duplication. It means that this is in TB, we need to deliver a suite of different medicines with different mechanisms of action so that we can tackle this mycobacterium from lots of different angles. And so that, I think, is an example that's worked quite effectively, and I think that should and could be moved into different disease areas. And I think pharma traditionally has been quite competitive, and we like that sort of competitive edge, whereas in this case you could just see that the opportunity to accelerate discovery. And I just wanted to come back to this notion of more disruptive technology, to be really thinking about access by design, and to challenge not just big pharma but biotechs and academia to be really thinking innovatively about what you would think now is just an impossible dream, but actually could leapfrog and really drive that access in a way that we never thought possible.
It makes a big difference if you start out saying we need a product that is long lasting, or that doesn't require cold chain, or whatever, or costs only this amount. It makes a big difference in the innovation process if you start with those constraints. I know, just thinking about your sanitation challenge at the Gates Foundation, I think the requirement for any of the teams that are putting together these fascinating engineering products on kind of the future of the toilet is it can't cost more than 5 cents per user per day. And you need those constraints if you're going to innovate for the markets we're talking about. Go ahead, Kevin.
Well, look, I just, Seth used the word prioritization, and I think this is so important, because what health system planners are doing every day and in their plans every year is essentially prioritizing who gets access to what treatment. I mean, that is what health planning is ultimately about. And I would say that any health system that is not prioritizing the well-being of the children who are at risk of the most fatal consequences of illness are not doing their job, and they're failing the basic tests of efficiency and equity and so on. And if you look at the reality of if you take child mortality as a good barometer actually of where these risks are, we know from demographic and health survey data, from a lot of other data as well, that children who are born into the poorest 20% of households are typically 2 to 3 times more likely to lose their lives before the age of 5 than children born into the richest 20%. We actually know that the poorest 20% of children account for about 40% of under 5 deaths globally. So I would say in a country where you have a high burden of childhood mortality, this is where you have to prioritize. You need to know who these children are, where do they live, what are the diseases. And you'd have to say the misalignment between what we know about where those risks are and where the resources go is extraordinary. There's almost an inverse relationship, actually. The greater the risk you carry, the less likely you are to get access to a fair share of public finance. And I would say that just as one really good example of what I think you were driving at, Raj, on the technology side, if you take a really basic commodity that we're all surrounded by in this room, which is oxygen, which is vital for the treatment of the biggest killer of children, which is pneumonia. It's vital for the treatment of sepsis. It's critical in so many other areas. There are many parts of the world that we operate in where oxygen is not even the remotest possibility. And oxygen is produced in capital cities, in big plants that put it into canisters, that then truck it over hundreds of miles to other parts. It's inefficient. It's inequitable. People end up paying for their little canister and they can't afford it. So I would say this is one area that is just crying out for innovation. I think it defies imagination that we're letting so many children die for want of oxygen. I mean, that is an extraordinary failure of the market, of our business models, of us as NGOs and of the health community more widely.
Is anybody working on oxygen now? Anybody working on that now? Are we familiar with this, Trevor?
There's a lot of work on oxygen. But not enough, actually. You know, one of the most exciting products, for instance, that is coming along is a dry powder form of surfactant. So surfactant is the molecule that's deficient in the lungs of premature kids, and one of the main reasons why they have difficulty breathing. In the US, you would get an artificial surfactant through the intubation in the neonatal intensive care unit. But there's no product that a kid in a poor country would be able to access. So there's a very hopeful dry powder, much cheaper form of surfactant coming along. You don't need to be intubated, you don't need a neonatal intensive care, but you do need oxygen at a minimum. And you do need CPAP. So, you know, it's still not going to reach that broad population until we solve that problem.
Thank you for bringing that here. I want to go to the floor very soon. And so I want to just give everyone fair warning to please start thinking of some provocative questions. Let us know what we're missing in this conversation so far. And we have a couple of special guests with us that we're going to bring into the conversation as well. But before we do that, Seth, go ahead.
Well, I just wanted to say something because we are talking about innovation, about innovations in financing. And Kevin's already mentioned the advanced purchase equipment. I thought I might explain that because of the usefulness for these type of products. So, you know, a number of years ago, there was a pneumococcal vaccine. It didn't have the most common strain in developing countries. It was quite expensive. And a new instrument was set up where $1.5 billion was put aside. And the idea was if companies produced to a targeted product profile, and they were willing to come out with a low price, a tail price right away, so countries would know, gee, I can afford this eventually, then they would be provided a top-up. They could go to their shareholders and say, gee, we're getting money on top, which just comes to us. It'll help cover some of those R&D costs, et cetera. So it was a win-win situation. And within 5 years, pneumococcal vaccine was available in 57 countries. It's now coming up to 60 countries. And, you know, the price point is 1.5% of that in, you know, for example, the United States market. So the reason I mention that type of model, which took some courage for donors to put that money in, but, you know, those top-up payments could be any level. So if you're thinking about how do we work with companies to have antimicrobial resistance drugs where you don't want them widely used, well, you could make a very big top-up payment, or you could use it for other types of interventions. So it's not just the drugs and the delivery systems, but it's also innovation in financing.
Pauline, that makes me just want to go back to something you said earlier, which is that these markets are not financially that attractive, which makes some logical sense. But is there an angle here where they could become more of a financially attractive option for the major pharmaceutical companies of the world in order to incentivize more R&D and innovation? I mean, the volumes are certainly large when you think of the number of patients that we're talking about.
Yeah, I mean, well, I think you've answered the question actually in terms of it is around the volumes, and it is around that sense of confidence that the number of sales obviously is going to drive the costs down. So I think that's a very clear link.
Okay, we're going to come back to some of these themes in a moment, but I want to bring in Dr. Marie Kemese Ngom Ndiaye, who is the Director General of the Ministry of Health and Social Action in Senegal. Thank you so much for joining us here. And Dr. Marie will be speaking in French. We have someone who will quickly translate it for her as well, for all of us. But we'd like to hear your intervention about what's happening in Senegal, please.
Merci beaucoup pour cette invitation à la 74e session des Nations Unies. Et comme je l'ai dit tout à l'heure, nous nous réjouissons de cette invitation et nous donnons un grand bonjour à toute l'assistance. Et dire qu'aujourd'hui, le partenariat doit aller au-delà de la science, parce que comme vous le savez aujourd'hui, nous avons les 3 piliers du système de santé qui sont correctement remplis. Il faut savoir, nous avons des ressources humaines de qualité qui sont renforcées. Nous avons également des infrastructures qui de plus en plus sont accessibles. Nous avons également des équipements qui sont quand même avec la technologie et les innovations haut de gamme, à tous les niveaux, du niveau primaire jusqu'au niveau des hôpitaux avec les spécialisations. Mais nous nous posons la question, pourquoi ça ne marche pas? Malgré tout ce qu'on a sur le plan mondial, nous pensons, en tant que médecins de santé publique, cela ne marche pas parce que nous n'avons pas adapté toute cette technologie centrée à l'être humain. Aujourd'hui, nous pouvons avoir des scanners, nous pouvons avoir l'IRM. Mais est-ce que nos populations ont réellement besoin de tout cela en un temps record? C'est possible, mais nous pensons que parfois, cette technologie, ces innovations sont excessivement chères pour nos populations. Quand vous voyez aujourd'hui tout ce qu'on a comme équipement dans nos pays, mais ces équipements n'arrivent pas avec les procédures de maintenance. Donc, dès que les équipements sont en panne, nous avons des problèmes pour le renouvellement. Et cela coûte excessivement cher aux pays, en tout cas, de faibles revenus, surtout dans les pays africains. Si je prends les produits de santé... Ah oui, j'ai oublié.
All right, so, all right, it works now. Can you guys hear me? It's okay? No.
Should be green.
All right. Okay, I'll try now. So, so Mary's thanking everyone for the invite, and we need to talk about partnerships beyond science today, and they want to understand why the system doesn't work while they have 3 strong pillars in place, which is a trained healthcare workforce, they have strong infrastructure, and they have high-quality instruments. So she's asking the question, why it doesn't work? And her answer is that we need to have a system that's more human-centered, and they have a lot of high-end technological equipment in their clinics, but many of these equipments stop working after a few months or after a few years, and they do not necessarily have the maintenance services to make it work or to keep them working, nor the financing to do that.
Thank you. Si je reviens sur les médicaments, nous avons en Afrique près de 80% des plantes médicinales. Nous pouvons également vous fournir, vous pays développés, de la main-d'œuvre. Mais pourquoi le médicament est encore cher chez nous? Parce que tout simplement, les usines sont implantées ici dans les pays développés. Et il y a trop d'intermédiaires entre le fabricant et celui qui va consommer les médicaments.
Very simple point about the production of medicines. Why the medicines are not produced directly in the countries to take the cost down, while they have all the medicinal plants available in the country and could host some of these factories to bring the cost down.
Nous voulons beaucoup investir dans la santé, parce que investir dans la santé, c'est renforcer les conditions économiques et sociales des populations. Donc les pays vont être encore émergents. Mais comment il faut investir dans la santé? Nous pensons que le partenariat doit être gagnant-gagnant et adapté à nos réalités. Est-ce que nous avons besoin de toutes ces constructions? Est-ce que nous avons besoin de tous ces équipements? Parfois oui, mais parfois également non. Et nous voulons vraiment, dans des assemblées comme ça, qu'on soit davantage invités pour expliquer réellement ce qui se passe aujourd'hui dans nos pays.
So they need to further invest. Yeah, they invest a lot in their health systems, and they want to have win-win partnership. And she asked the questions: why do we need all these equipment? Some of these equipments are needed. Sometimes we have too much. They really need to go back to human-centered healthcare delivery, and further and be more invited into these debates directly to develop those partnerships and share their actual needs. So the solutions that are developed take into account the actual needs of the patients who we are trying to serve.
Thank you for that. I do want to bring in our other fire starter, if he is here, Adrian Thomas. There you are. We are very lucky to have Adrian Thomas, Dr. Adrian Thomas, who is Vice President for Public Health at Johnson & Johnson. And please also tell us what we're missing in the discussion, Adrian, if you would.
I'm not sure you'll be grateful in a second. First of all, I want to start before we all get depressed. You all ought to read Hans Rosling and Ola Rosling's book, Factfulness, because otherwise you'd leave this room and feel like going to the nearest bar. The fact is that over the last 50 years, there have been tremendous strides in human health and human development. So we should remember that we're actually working from a position of relative challenge but an improved position than we were. And I think it's up to us to really recommend and challenge all of us to take this forward in digestible, absorbable, incremental steps and work towards a better future, not to sort of divide and conquer. I want to make a couple of observations. I think the field of global health has been characterized by trying to find the most needy patient that's worth the most money and targeting siloed approaches. And we can do that, or we can say, the issue actually is fragile health systems and the inability of the system to react to crises, the inability to give basic primary care and so on. Because we always find in these discussions, there's a lot of money in global health. There's money in HIV, in fact, the Global Fund, HIV, TB, malaria, but the system is siloed. HIV, TB, malaria. That same person lives in a village with diabetes and other sorts of things, maternal and newborn health issues. So we have to think about how we move the incentive streams around the person, around the community. The second thing I said, I want to recognize all of you because you're all leaders in this space, and I work in the global health field for J&J. If I think about TB, we now have the, I think, difficult position of seeing a wealth of technology come down. After half a century of no new technology, we have at least 3 new drugs. We have a new regimen now. So from 12 to 24 months of toxic, let's say, intolerable treatment for drug-resistant TB, now we have 3 drugs, all oral, 6 months. Just been approved 2 months ago. We have over 6 new diagnostics going through WHO. So we have this embarrassment of riches, but our experience, I'm sure GSK's experience, Otsuka's experience, the Gates Foundation's experience has been, we now have the technology. How do we accelerate the adoption? Where's the system ready to receive it? And our experience is 5 years after the approval of our drug, bedaquiline, we're just now seeing acceleration, 5 years later. And we're fortunate that the high-burden countries are relatively concentrated. There are many parts of the world that will never have adoption, even though it'll be 10, 12 years from now. How do we fix that? Because if we don't fix that, then bringing in new innovation is kind of difficult. I think one of the challenges for the developing world is there's going to be so much new innovation. How do they absorb it? And I'm interested in this group here, because that's my very, very specific fire starter, is many countries in the world have issues with health budget. They're kind of first world issues. And we have huge amounts of budget, but we don't have any more. They do horizon scanning. They meet with the industry. They meet with stakeholders and say, 5 years from now, what is coming? How can I create room for that in my budget? What are we doing in the developing world to say, let's move away from this as being a philanthropic issue or a humanitarian issue? It's a business issue, even for governments. How do I create room, a national strategic plan, make sure we have absorption? And it's not at the global layer, it's not at the multilateral layer, it's at the country level layer. Have you seen that? How can we think about accelerating that in other countries? And then how would you engage with it?
Well, thank you very much. You both did exactly what I was hoping for, which is to push us a little bit here on the panel. And there are many threads that we could pull on. So I'll see if anyone here on the panel wants to begin. One that maybe came between both of those fire starters is around the need for a more human-centered approach. I think the language that Adrian uses, a human-centered incentive stream. Do we actually have the incentives aligned around that? And he, of course, was giving the example of bedaquiline as one example in the TB space. So any quick reactions to that, Trevor or Seth? Or anyone? I see you nodding. Go ahead.
Well, yeah, I just would put in what Marie was saying around the issues of lab services. So you can't introduce any innovation, TB or otherwise, unless you can actually diagnose things. And we've all seen the laboratories in many regions where equipment is out of use because it's not been repaired. How does one take account of that? On the innovative financing situation, there are hopeful trends over there. So, for instance, the European community, together with the European Investment Bank, has made a facility available for governments to access in partnership with private diagnostic companies an ability to purchase diagnostics. And they would support that investment strategy. So it would be on the government side and on the companies to participate in that. And then you'll fix to some extent via that mechanism the issue of equipment out of order. So I think that, we do have these innovations on the finance side, but it's a question of how do we get uptake even at the government level and the company level to these opportunities.
Go ahead, Pauline.
I was just going to pick up on a point that Adrian made, which is around the siloed approach and starting to think about, introducing one technology, one patient, and actually it's not just that patient who may have morbidity, but also their family, their community, and it just struck me. I wasn't expecting this photo when I came in, but this was me on a particularly bad hair day in Bungoma County with the Save the Children signature program, and this was actually for me to see the chlorhexidine gel being used in a managed access program, but it was part of a signature program that Save were running at the time, which was using the chlorhexidine gel introduction, but as part of a larger campaign which included adolescent sexual health education, antenatal care, introduction of KMC, kangaroo mother care, and multiple other things in terms of community sensitization. And so that was a really great example of seeing one medicine being introduced, but as part of a much larger holistic approach, which I think was really impressive.
Seth.
So first of all, I think your challenge on how to do this, it does relate to having more resources. And that's a really important conversation, and it isn't a health conversation. That is about a government conversation, it's an IMF conversation, and it's about a value of taxation. I mean, we have some leaders that say only, stupid people pay taxes, and in many countries, the tax burden in Africa is 1/3 of that in OECD countries in terms of percentage of money that comes from that. So this is, a really big problem that I'm hoping will get more attention, as we're seeing now, African Union, other groups coming together and talking about that. But then the second part of it, obviously, is, where it gets allocated. And our chair is a minister of finance, and she loves to tell the story that every minister came to her and said, I need more money for this or that or the other thing, and it added up to well more than 100%. So you do have to then, as a minister of finance, make these decisions, and then you have to give them the data. I mean, vaccines, beautiful, $1, $54 in benefits, we have that. What is the data on a health system? We have a hard time measuring that. We know it's real, we just have a hard time measuring it. So this is going to be one of the challenges, is how we make the case for these interventions and be able to sell them, because otherwise it will be, we advocate for our favorite disease, and that's how we do it, which is not the right way.
Great comments, by the way. So thank you for those. So I think this incentive issue is a really critical one. And, incentives, in the end, have to start with political leadership, where, you say you look at the burden of disease across the country, where the risks are, and you incentivize your health providers to respond to those real risks through a system that actually makes them accountable to the communities who are bearing the risks. So I think that's a general governance approach. And I think, as we're all aware, issues of absentee health workers, inappropriate treatment, this is not something that is done well in many of the countries that we're talking about. In the spirit of debate and dialogue, the thing I would push back on a little bit is the Hans Rosling view of the world, which is clearly accurate. And I think Hans was arguing against the extreme pessimism that people like us often generate when we get together in a room. And there has been extraordinary progress. But I would also say, if you look at it from the other end of the telescope, the gap between what we're capable of and what we do is wider than ever in history. So, it's both true that we've made unprecedented progress, but it's also true we're falling further short than we've ever fallen of what we're capable of. And I do think, like Seth, actually, that a lot of this does come back to financing questions. That you cannot develop a health system approach and get away from vertical disease-specific interventions unless you build the system. Now, before, Raj, you mentioned that it's not untypical a country like India spending 1% to 2% of GDP on health. You are not going to tackle these big, deep equity issues against that background. But the reality, of course, is that is what the government is spending. And the less the government spends, the more people will spend out of their own pockets. And that incentivizes the wrong things. I mean, that would incentivize the mushrooming of private sector providers who are largely unregulated, who are often providing appalling quality care to people who need it. So, I do think, if we can't tackle the problem of how do you finance the system, all bets are off on a lot of what we're arguing for here. And I do go back to the point that, Trevor, you mentioned that innovative financing. There's a lot of talk of innovative financing. The most innovative financing thing most governments could do is put in place a proper tax structure and an equitable public spending system. I mean, that would be innovation big time. We've been discussing Nigeria. Nigeria collects 12% of GDP in revenue. This is a completely implausible revenue collection scenario for a country that's committed to universal health coverage. So, I think a lot of this does come back to these really fundamental financing questions.
Yeah, great points, and many of the countries we're talking about, I think in India, the out-of-pocket expenditures make up more than 2/3 of healthcare expenditures. It's the same thing in much of East Africa and West Africa. So yeah, it's a very important point to bring up. I do want to go to others here in the audience for more questions. I see several hands, which is great, and yeah, all over there. We will take, let's see if we can get 3 at once. And then we can try our best to respond to those and come for a second round. So
that means I asked 3 questions, right?
Half a question. How about that? And please just tell us your name and organization too before you start.
Chris Maddox, Seed Global Health. I just wanted to come back, thank the panel, obviously. Oh, there we go. I'm on. Thank you. Chris Maddox, Seed Global Health, Health System Strengthening NGO working in East Africa. I want to thank everyone, obviously, for being on the panel and remind us that we are looking at the steps beyond the science. So with all due respect, we have talked about compounds and delivery mechanisms and surfactant and many great interventions. But in the 2030 agenda, we also have targets for the human resources for health, which we all know are going to swell to 18 million gaps in doctors, nurses, and midwives. So we're going to talk about financing. We've already been there. But I think that there's also a question of leadership. And I want to put this challenge to you all as leaders who have been tremendously successful in mobilizing resources, getting the public and private sectors to the table, accelerating R&D. How can you also be those best spokespeople, not someone else's problem, but the problem, Seth, you said 85% of interventions get delivered by primary care. It's not been on the conversation, right? How we do that. So I guess maybe how can you make those commitments from your podiums, from your platforms, to be partners and advocates for that case, as well as for the zip lines and the next generation of investments? Because those investments of people are those future-facing things, right? We train somebody today, they're still practicing in 10 years. They're there to deliver vaccines. So I'll end it at that.
Thank you for that. And I think do we have a mic on the other side of the room? We'll come around, go to the front row here.
Hi, thank you. My name's Jenny. I work at Stop AIDS based in London. We do a large amount of work on access to medicines. Raj, you were asking about what's missing. I'm deeply disappointed that there's no patient voice in this panel. Like, where are the people who are affected by the gaps in access to medicines in this conversation? I'm also struck by how we've consistently talked about access issues in low-income countries and not really made any sight of the problems in high-income countries, like in England, where I'm from, where kids can't get access to new cystic fibrosis medicines because the pharmaceutical companies are holding the NHS to ransom at unaffordable costs. Yesterday, Jeremy Corbyn at the Labour Party conference made a massive announcement that if Labour were to come into power, that he would dramatically reform the R&D system and the kind of medical system in our country to increase access to existing and new medicines. And I wonder, I'm sure the panel is maybe aware of this announcement. I just wondered if they could respond to some of those more radical ideas about how we can create more equity in this system, which is dramatically lacking.
Thank you for that. And then we'll move over here. Sorry to make you run all over with a microphone. Thank you.
Thank you very much for the informative session. My name is Dr. Kanupriya Agarwal. I am a physician entrepreneur in digital health. I have a 2-part question, and I'll be quick. So as we talk about the developing world, why is the piece on Latin America often missing? And the second question is, as someone working in digital health, I'm curious to hear what are the key challenges that you might have faced in implementing or integrating digital health to deliver some of the goals of global health in, around the world? Thank you.
Okay, thank you very much for all of those. We will try to come back around for one more round of questions. I appreciate all the enthusiasm to join this discussion. So 3 broad points, if I can sum up, and we can pick up any. We don't feel like you have to answer all of these at once. But a key question around the 18 million person gap, the healthcare professional gap that's predicted by 2030 in the low-income parts of the world. The idea is there, the estimates are there will be 40 million new jobs in the healthcare workforce globally, but most of those will get filled in high-income countries, and there'll be a gap of 18 million. So maybe we can talk about that. There's a great point by Jenny here who has said that we're lacking patient voice. We're talking a lot about a human-centered approach and a patient-centered approach. We don't even have the patient voice. So maybe we can get into that discussion. And also even thinking about the politics a bit, both here in the US and in the UK, many other high-income countries, pharmaceutical pricing is a big political issue, absolutely. And we heard a question about Latin America missing from a lot of these discussions. Again, very true. So if anyone wants to pick up, I see Seth leaning forward. Please go ahead.
The human resources for health question is absolutely critical, and there's multiple components to that. So first of all, it shouldn't be solved by individual initiatives. You already heard about why we shouldn't be having separate programs, and that's been a challenge because it's also not sustainable. So the idea that you pay somebody to do HIV care, you know, off budget, et cetera, can't be there. So it has to be country solutions. Now, the country solution problem, frankly, is complicated, partially because of the public budget we talked about and the pressure on countries to reduce their public, salaries and expenditures. But the other thing that's really interesting is, do we need doctors to be delivering care? And can we push care down? And so as we think about primary health care, and this is where digital technology really makes a difference, you can deliver so much care by well-trained workers who can treat 15 common conditions with backup with digital technology where they can ask questions and refer people if necessary. But to do that, you have to have a mind shift. And I think, to me, that's where we have to go. But that has to be a whole sector-wide conversation and not an individual disease conversation. And hopefully, as part of the SDG 3 roadmap, we'll get to that conversation, which is very important.
Just to echo that, really, I used the example a bit earlier of the proportion of children in Nigeria with acute respiratory infection symptoms who are taken for treatment, which is around 24%. In Ethiopia, it's 3 times higher than that. And I think that's partly because Ethiopia has invested very heavily in exactly what you're describing, community-based interventions on nutrition, basic child and maternal health.
Using Gavi and Global Fund money and pooling it at their request.
Yeah. So I think pooling is really critical, and the overall resourcing is important as well, because Ethiopia also spends a bigger share of its budget on health than Nigeria. Obviously, a lot of this week, I've been very abstemious in commenting on UK politics for reasons that I'm sure everybody will understand. So I think it's a good point. So one of the things that we do in a lot of our research documents is that we do interview, especially mothers of children who are struggling to get access to care. That's not a substitute for them being on this panel. That's a fair point. It's also the case, I've been very struck by some of the discussions I've been in this week on Leave No One Behind, which is one of the rallying calls, as everyone will know, of the Sustainable Development Goals. And at the heart of the commitment that governments made there was that people who are furthest from the goals would progress much more quickly than people who are closer to the goals. And we were all told when the SDGs were adopted that these would apply to rich countries as well as poor countries. And I have to say, you have to admire the way rich countries have really kept out of the spotlight this week, because a lot of them are doing pretty appallingly. The UK isn't doing particularly well, even on basic indicators like child survival, where the gaps are very large and the gaps aren't coming down. the US actually has some of the biggest disparities in child survival between, if you take the extreme top end of children born to white mothers in the top 20% versus children born to black mothers in the bottom 20%. These are deeply institutionalized disparities that I think quite rightly are at the heart of public health debates here in the US, including debates over drug pricing as well. So, thank you for drawing attention to that. It's a really important point to make.
Go ahead, Trevor.
Yeah, so, I think one fundamental issue, Adrian had alluded to this, but comes up with a number of these questions, such as we need to improve healthcare systems. Governments need to allocate their resources much better than they possibly do right now, has been the tremendous data gap. There's a lot of data out there, but it's not been in a usable form for governments. Last year, India published its first subnational burden of disease. This year, for the first time, we see the subnational burden of disease in Nigeria and Ethiopia. Now, a lot of those efforts have been by, very substantial and excellent external partners, such as Institute for Health Metrics Evaluation, who's been a big sort of analytic driver of that kind of analysis, working to some extent with in-country data scientists, epidemiologists. But I think that the next phase is that data needs to be turned over really in very usable form to countries by developing capabilities exactly in this area of data science, epidemiology, that is going to be useful to governments, to ministries of health, that they can use to actually petition their Minister of Finance for the resources they need.
Go ahead, Pauline.
Well, just to pick up on that point, I think I spoke at the beginning about the need to understand the future state in which our medicines are going to land. And I think resources like IHME and that modeling capability, that data analytics to be able to look at that future state is going to be invaluable. I did want to pick up on a point that was made by the Minister of Health for Senegal, which is around why aren't we making the medicines in those countries? And I think that's a really important question. And that raises perhaps a bit of a rabbit hole about intellectual property, in which regions do we go for patent protection, but also voluntary licensing. And I think there is, GSK has got a track record, particularly with ViiV, our HIV company, where we do work with local in-country manufacturers and give a voluntary license in order to drive that access.
I know we could go on further here, but I do want to try to get to some of these many other hands that are in the air. So I think there's one here. I know there's many here too. Believe me, there's many on this side. We'll start here, we'll go here, and then we'll come over here for one. Go ahead.
Thank you so much to the panelists. I think there's an undeniable power to partnerships.
And please just tell us your name and organization, if you might.
I'm sorry, Natasha Sunderji, Global Health Lead from Accenture. I was stating that there's an undeniable power to partnerships in the health space when applied to the right issues, with the right partners, with the right resourcing behind it. At the same time, we can't deny the power of competition, whether it's driving innovation or driving down prices. And I'd love to better understand from the panelists where you see that line between collaboration versus competition across the value chain, whether it's identification of needs, development of new technologies, deployment to the right populations at the right time, to monitoring and evaluation.
Thank you for that. If we can get the mic just over here.
Sky Gilbert, Digital Square at Path. I think as I think about the timeline in 2030, I think in the digital health sector, this is building on some of Priyanka's comments, over the next 9 years, the market's going to mature, and we're going to have a lot of decisions to make around what that innovation ecosystem looks like, where the R&D is concentrated, how we scale. I'm wondering, for that and other health innovations, what do you think we should be adopting in market shaping efforts from pharma, and what should we be thinking about doing differently?
Thank you. Just here in the second row. And
thanks. Camilla Knox-Peebles, Amref Health Africa, UK. This week, world leaders adopted a political declaration on UHC. It's a really exciting moment. And I was just wondering what you will be doing differently as a result. You're powerful leaders. You've talked about country leaders and their responsibility. I'm just wondering, what will you be doing to hold them to account? Thank you.
Thank you. And actually, we'll take one more. The gentleman with the glasses here has been very patient. Thank you. And I know there's more hands back there. We'll come around another round if we can.
Thank you. Dorji Mundal from the Health Finance Institute. My question is kind of alluding to kind of what was mentioned many times during the UHC political declaration about the dual burden of disease. We know that the explosion of the silent tsunami of NCDs, in addition to all the traditionally prioritized therapeutic areas that we've been talking about today, has got huge implications for healthcare delivery. In Europe, we've had for decades private pharmacies, healthcare delivery, distribution being integrated into universal healthcare. And we see that more and more in Ghana, in Rwanda, in kind of other developing countries. So I'd love to hear the panel's thoughts on how we can, where we should and how we can better integrate private healthcare delivery and distribution and so on into universal healthcare for 2030.
Maybe we can start there. There's a lot here, obviously, to unpack, but there's a lot of expertise in the room. I want to try to get as much into the discussion as we can. Maybe we can just start with the role of the private sector. It's come up a little bit so far, but how do we see that evolving? Trevor, do you have a take here?
Roger, I think that unfortunately the private sector has been seen to be somewhat at odds with the public systems in a number of countries. But I think we're starting to generate enough examples of where there can be a tremendous synergy that we can use those as best cases. You take the situation in India, which has got the biggest TB burden in the world. And that's treated usually in the first instance within the private sector, could be informal private sector. And there's been a new effort which is now being rolled out nationwide around a partnership to supply drugs, the correct drugs, to these informal providers from the government and to track them through call centers. This is part of something which is called the 99 dots system to enhance compliance for TB. So it's really the first good, I think, partnership example we've seen in the TB world in India between the government and this informal private sector where most people are being seen. So it's those kinds of examples which I think are going to lead to an increase in this very necessary partnership.
We had a question around market shaping and one around competition versus collaboration, and it kind of fits a bit into this question of private sector. Go ahead, Seth, maybe you can pick that up.
So in terms of private sector engagement, I think the critical issue, it depends upon what the intervention is. You have to, for the basic interventions like immunization, not have that driven by the private sector. The private sector can deliver vaccines, but they have to do it free of charge, without user fees, because this is something we have to get out to everybody. And so it's being able to have that differential, and that, of course, is difficult because it's hard to legislate. In terms of this question, partnerships versus competition, it's a great question. The way we think about this is we want as wide a partnership as possible, get everybody engaged that can potentially be there so that we can align and drive the whole field forward. But when it comes to individual vaccines or individual technologies or individual ways to work, we want as much competition as possible. And it's been remarkable how that competition has led to, you know, higher volume, lower cost, has led to multiple new product profiles that have been better. And so I think we need to keep in mind that competition always has a role to play. So you have to have both of them, in essence, playing off each other a little bit.
I'd love to get Pauline's take on that exact issue, because you talked earlier about the opportunity for collaboration. But where are there sort of pre-competitive spaces you can collaborate, but yet still compete later? How do you think about that?
Oh, gosh. Well, I think we have got, well, I'll give a specific example, actually, in terms of open innovation that we have with the Tres Cantos Open Lab. So this is GSK's R&D site for diseases of the developing world, just outside Madrid. And we have a foundation that's an independent charity that funds academics to come and work alongside us and access our compound library, our screening, our in vivo assays, et cetera, et cetera. And all of that is open innovation. And that's been extremely effective. But then once that has completed and that piece of work reads out, then that is open to anyone to then pick up and take forward. So it's not unique to GSK, it's not unique to the institution, it's open there. So I mean, I think that's a very early example, but one that I think has been really quite effective, and I hope is a model for how it could be used elsewhere.
So, go ahead.
Sorry, I was going to answer the market shaping thing, because I think it's kind of a term that sort of strikes fear into the pharmaceutical industry, because we've got very, very strict policies around, you cannot do anything around promotion of a product until it's approved in that country and you have a label, and then you can only talk according to that label. So anything that happens before that that's market shaping, you've got to be really, really careful that you're not kind of contravening all of those very valid rules and regulations. That's slightly different from an advocacy role around, if a product were to meet this target product profile, what impact would it have? And so when we talk about the role of partnership in that context, I think that's where certainly the voice is much, much stronger when it comes from outside the product license holder than from within.
You know, we haven't yet brought up, Kevin, I want to hear your thoughts on whatever you want to respond to, but we haven't really talked about the UHC political declaration. There was a question about this. Does it change things?
I will comment on that, but just really briefly on the competition point. So what I would say is I think it's self-evident that competition is absolutely critical here. You know, the Seth wants competition to drive down the cost of vaccines so that you can reach more people. I mean, you know, we are reliant on the products that come out of competitive industries for delivering the sort of services that we deliver. And I think there are so many areas where, you know, we do need more innovation, and competition is the handmaiden of innovation in this context. You know, I've mentioned oxygen. You know, there are other diagnostic technologies, affordable pulse oximetry, all of that sort of thing where we could be doing a lot more. I also think the cooperation part of the agenda is critical. You know, one of the things that we're a member of is this Every Breath Counts coalition, which is focusing on pneumonia, bringing together industry, civil society, Gavi, multilaterals, and so on. Now, on universal health coverage, I think it's such a good question, because the thing about governments when they come to this city at this time of the year in particular is that they're prone to promising pretty much anything. And you know, we've had no one's going to be left behind. Now we're going to have universal health coverage, universal education, universal this, that, and the other. And the reality is, let's be honest, most of the governments that are coming here and making that declaration are not acting on it back home and have absolutely no intention of acting on it. So I think what we need to hold governments to account is really clear criteria that will measure their performance against the commitment that they've made. And I think there are indicators, like, if you believe in universal health coverage, how rapidly are you cutting the death rate gap between the richest 20% and the poorest 20%? How quickly are you cutting the gap between the children who are non-immunized and children who are immunized? So I think it falls to us as civil society and others who are interested in this to establish really clear criteria against which those governments who have made that commitment, and there's a financing element to that commitment as well, by the way, which governments have to be held to, that you can't have levels of spending that by definition mean that you will be impoverishing people because they're paying out of their own pocket for what you call universal health coverage. So that's something that in Save the Children, we will be working very actively on. We're very strong advocates, obviously, of universal health coverage. But I think, a great sounding commitment, a great sounding slogan that governments can't be held accountable for is not what we want to come out of this.
Can I just add to that? Because, of course, UHC is a great sounding slogan. Nobody could be against it except perhaps the U.S. But the really interesting question is, what does UHC mean for every specific country? For Central African Republic, that's different than Senegal. That's going to be different than it is for Brazil. Then it's going to be different than France. And so each country has to take that forward with the principles that Kevin has talked about. And I think what's really important that now is to work on giving countries what those details are. And some of the principles we talked about having adequate finance, of having allocative efficiency, of making sure that you don't tip people into poverty. These are the key pieces, but there's going to need to be guidance and work to really try to create programs that make sense. If that doesn't happen, it'll remain a slogan, but if we can get there and countries can act on it, we can really move the needle. The one risk is that if we don't know what we're doing, we could easily, for example, put insurance schemes in place, not have adequate money for those insurance schemes, and actually do allocative inefficiency, where we take money away from prevention or really critical interventions to fund, hospital-based care that is much less efficient. And that's happening now in a number of countries. So this is something we're really going to have to work hard, and you're right, civil society and advocates have an important role to play.
This is where the financing piece is so important, because if the pie is not growing, then it becomes a competition over resources, and we might underinvest in prevention and primary to fund things that are more politically popular in urban centers. It's a real challenge. We are running out of time, but I wonder if I can go to you, Trevor, for a thought. You're thinking ahead to 2030, which is the UHC goal here and the Sustainable Development Goals. What's going to be different about the conversation we're having now? I mean, is this going to evolve in some new way? We've talked about some of the new technologies. We've talked about new approaches to private sector working together. There is new tech, of course, in the information side, as well as you brought up earlier, gene therapy and gene editing, some pretty radical ideas in how we deliver therapy. So as you look out at this and you've got a big portfolio to invest in, how do you think about this going forward?
Raj, maybe I can best link this to the UHC discussion. One of the exercises that we've been trying to support is the measurement of all of these exercises. And the measurement in terms of what will the world look like in 2030, and looking then at the downside if things don't go well on certain factors, and the upside if we really do well and the stars align. I would say that that exercise of projecting to 2030 is going to get ever more precise, and that's going to be the information that the health ministries need with the finance ministries to make the allocation discussions. So I'm hopeful that we'll get to a much more rational system. I would say a big unsolved problem to my mind, and this is a debate that's going on more generally, is how exactly do we measure UHC? It's a very difficult thing to measure when you have to measure it with a global definition that covers France as much as Central African Republic. And to the extent we get UHC in 2030 will be the success we have in the next couple of years establishing our metrics and then knowing where we're heading in respect to those.
Right, and thinking of all the elements of UHC, thinking of not just access, which in some ways we're doing well on, but on quality, which we're often not doing as well on, and on cost, because if getting access to healthcare bankrupts you and puts you into poverty as it does for 100 million people a year, then we certainly have not achieved real UHC. I want Pauline to close us out, but I think we have a comment from the Director General in Senegal. I'd like to hear that first, please.
Voilà, merci encore une fois. Je pense que notre ami de Save the Children a déjà bien conclu. Moi, je vais dire que la couverture sanitaire universelle, au-delà de ces grands engagements, c'est en fait la couverture locale dans chaque pays d'abord, en tenant compte de ses besoins réels, en les priorisant, mais également tout cela autour des déterminants socio-économiques, environnementaux et culturels. Il ne faut rien emprunter, ni à Jean, ni à Paul, ni à l'autre, mais rester dans son propre pays et ensuite s'ouvrir. Nous le pensons ainsi. Merci.
So she kind of agrees with you, Seth, saying that we first need to focus on delivering on local coverage in each country for health, based on each country's priorities, taking into account cultural, environmental, social, and economical determinants of each specific situation.
Yeah, starting from the basics, I think you talked earlier about the prioritization and the phasing. Pauline, any final thoughts as we close?
Just a plea, really. I mean, I think there's a lot of people in this audience who've got really valuable ideas and can advise us as the private sector, the pharmaceutical industry, the biotech industry, in terms of how best do we play in this space. So don't sit there silently and think, this is all a bit of a corporate social responsibility gig. Actually, what is it that we can be doing better? And please, we're in listening mode. So I would say, please do get in touch. Please do advise, because we want to do this right.
And just to close out from my end, we were accused, I think, fairly early on in the discussion of being a bit pessimistic. So let me offer an optimistic note, which is that although UHC is a pretty easy thing to sort of agree to, in one sense, it is a pretty radical agenda. The idea that world leaders would get together and be willing to say they support the concept that every person on this earth deserves, as a right, access to health care, that it be high quality and it be affordable, is a radical idea, and it's certainly far from the reality that exists today. But it's a tool, and it's a tool hopefully for all of us to use to go out there and push each other in this global health community, to push governments to say this is a basic human rights question and there are ways forward. We at Devex are obviously covering these issues every day. They are complex, but there are opportunities, and I think there is hope when you look below the surface at what's really happening, often at the local level around the world. So thank you, all of you, for being a part of this discussion today, and please join me in thanking this fabulous panel.